Good evening, everybody. Bruchim habayim. Welcome to all. I'm Rabbi Zachary Goodman, and I serve as the assistant rabbi here at Holy Blossom Temple. First and foremost, I want to extend my gratitude to everyone for coming out on this evening, despite the weather, and engaging with this very important topic. Whether you personally manage anxiety, love someone who lives with anxiety, or simply are interested in learning more, we are grateful for you being present tonight. Last spring, our group of Holy Blossom Temple members, professional staff, and clergy met to establish the Luke Sklar Mental Health Initiative as a tribute to this much-loved member of our community who died by suicide in May of 2018. Our mission is to provide education, support, and resources related to the challenges of living with or supporting someone with a mental illness. We believe that by talking about and supporting mental health, this initiative will work toward ending the stigma around mental illness and encourage others to seek help. This evening is the second program in what we believe to be a very moving speaker series. In March, we launched the Luke Sklar Mental Health Initiative by learning from Dr. David Goldblum about the challenges of living with depression. Tonight, we are incredibly fortunate to be learning with Dr. Martin Antony, who will be discussing the complexities and difficulties of living with anxiety. And we hope you will join us again in the spring when we will be partnering with the Jewish Addiction Community Service, JACS, to learn about the mental health field of addiction. We are incredibly grateful for your participation this evening and ask for your continued support. If you are willing and able, we invite you to please consider making a donation to the Luke Sklar Mental Health Initiative Fund so we can continue carrying on this important work. You may have seen we have tzedakah boxes available in the atrium as well as a donation link on the Holy Blossom website. While there is certainly no obligation, we kindly welcome your generosity and recognize this tzedakah as an opportunity to perform a mitzvah with a significant impact. The success of this initiative depends on our volunteers in the community to help with events, share knowledge and experiences in mental health support, and offer financial support toward the Luke Sklar Mental Health Initiative Fund. There are also a number of other wonderful opportunities to give here at Holy Blossom, so thank you very much for considering us as a part of your tzedakah. In the spirit of mental health, we recognize that the conversations surrounding this topic can be triggering for some. We are grateful to the Jewish Family and Child Services for providing social workers who are present with us tonight. If at any time during the evening you feel the need to speak with a professional, please seek them out in our Life Cycles room, which is just outside the doors behind me, and you'll turn right, and they're adjacent to the accessible washroom. Dr. Antony will conclude his remarks tonight by answering some of our questions. To pose a question to Dr. Antony, please follow the instructions on the handouts that were given at the registration tables. You can connect to the internet using the Wi-Fi network HBT Guest, and the password is Holy Grounds. Capital H, capital G, all one word, Holy Grounds. Great. If you prefer the old-fashioned way, we also will have a few volunteers with note cards and pencils who will be standing at the side aisles and just flag us down or come to us, and we'll make sure that your question gets addressed as well. The most popular questions will be curated and asked towards the end of the evening. We would be remiss if we did not recognize the power of today's National Day of Remembrance. I will conclude with the powerful words of Rabbi Ruvain Bolka, the honorary chaplain of the Royal Canadian Legion. As the troops fought and fight for freedom, ours is the supreme responsibility to give meaning to that freedom by embracing the language of respect, the language of inclusion, the language of harmony. That is the Canadian way. We love our veterans and the freedom we enjoy thanks to them. We remember with everlasting gratitude by giving meaning and substance to that freedom. Let us together soldier on toward that goal and may God bless our sacred partnership. Together we say, Amen. We'll now take a moment for silent remembrance. Thank you. Now to begin our program, we welcome Lise Sklar to the podium. Thank you so much for being here tonight.
Hi, everyone, and thanks for coming out tonight on this snowy night. Talk into the microphone. Can you hear me? Thank you, everybody, for coming out tonight. I'd like to introduce Hirsch Foreman over here, who has agreed to share his personal experience with anxiety.
And by the way, ask a person who manages anxiety to talk in front of a few hundred people. Perfect.
Okay.
Love it.
Okay.
But thank you.
Okay, so first some background. Hirsch describes himself as a husband, father, friend, and marketing professional with over 30 years of experience as a senior consumer packaged goods marketing, sales, and communications professional.
I was 3 years old when I started, just so you know.
Excellent. Hirsch is a senior consultant and trainer with Mindful Gateway Consulting, where he designs and leads training programs for leaders and others that increase focus, clarity, and resilience in today's always-on, complex, dynamic work environments. He's a part-time professor in Seneca College's School of International Business and Management, and also at the Centennial College School of Business. He's past chair of the Steering Committee of Mindfulness Toronto, a vibrant community of professionals dedicated to the principles and practice of mindfulness in all sectors of society. Hirsch is also a member of the board of directors of the Forest Hill Hockey Association, where he has held a number of positions, including being president from 2006 to 2013, which is probably a record. And importantly, Hirsch was also a longtime good friend to my late husband, Luke. So,
First of all, thank you for that introduction. It's almost as I wrote it myself.
Yeah. Okay. So, I wanted to thank you for agreeing to be here tonight. We had some discussions about anxiety as part of the committee, and there were people saying, who's going to talk? You know, they're anxious. Why would they talk in public? And so we're very grateful for that. So to begin with, will you tell me a bit about yourself and start with what you were like growing up?
Okay, first of all, I really am happy to be here. I'm here because this is a really important initiative, yeah. And as well as the initiative that Luke's company is doing, the Headway for Mental Health initiative in the business world. Yeah. And so I really believe it, and that's why I'm here. Because as I mentioned, you know, having someone who lives with anxiety speak in front of a few hundred people, most of which he doesn't know, is something that's obviously very difficult. But I've learned to deal with it, and I can talk about that. So what was I like growing up? Yeah. A little bit about my family background. First of all, I've lived in this neighborhood all my life, literally, since I was 4 years old. You could throw a baseball to my house down the street. The house that you guys park in front of for the high holidays. Don't block my driveway, please. Both my parents got married very late in life, very unusual for the time they got married. In fact, my mother was a feminist before the word was invented, and actually was supposed to get married to my father 7 years before she actually did, but she called it off, blew him off, told him he was a mama's boy and to grow up and come back when he was. And they met 7 years later and got married late in life. So I was born, my mother was 41 years old, my father was 44, very unusual for that time. I'm an only child, and I'm the son of an only child. So fairly normal childhood, going to school at Cedarville down the street here, where my kids also went to school. And then I had what was obviously a traumatic event at age 7. My father died at age 52 when I was 7 years old. And that was really, you know, if you ask me when did I first, start to notice my anxiety, although I didn't know what to call it back then, it was shortly after my father died. So I would say that after that, how did it manifest itself? I became very risk averse, very socially anxious, which people who know me later in life, there's a few of them here, would probably find very hard to believe because I'm somewhat of an extrovert. I'm used to actually talking in front of crowds and actually teach presentation skills at Seneca College. So people who knew me back then would not have guessed that I suffered from anxiety. And it also manifested in physical problems, lots of GI, stomach stuff, very risk avoidant, afraid to try new things, didn't go to camp, wouldn't travel places, was constantly concerned about health, either about my own or about my mother as the only person left without any siblings. So that was kind of how that event informed me growing up.
Did you know what you were feeling?
Yeah,
Can you hear? That's on, okay. At that point, did you have a name for what you were feeling? Did you know what you were feeling and what you were dealing with? I mean, now we're calling it anxiety. Did you have a name for it at that point?
Yeah, I don't think my mother at the time would have had a name for it, and I don't think I would have. Like, we're talking 1960s now.
Yeah.
And so certainly I wouldn't have called it that back then.
Okay.
You know, people would say he's a nervous kid.
Right.
Right? That would be the way it would be described, 40, 50 years ago.
Yeah.
But I certainly couldn't label it, or I didn't certainly understand where it was coming from. It didn't like it made sense to me.
So, at what point did it start making sense to you? Or at what point did you say, I need to do something about this, or this is not how other people feel, or what's going on?
Okay, so, as I grew up and went through school, I was able to manage it. I was able to basically manage it by pushing it down and ignoring it and turning away from it and trying not to think about it. Avoidance was the way that I dealt with it, and I'm pretty sure that's fairly common with the way people deal with a lot of mental health issues.
Yep.
I certainly didn't think of myself as someone who had a mental health problem at the time. But then I had a precipitating event, and I'm probably thinking this is early 2000s at this point, or maybe mid-2000s. So I was working in marketing for a large multinational, and one day at my desk, I had what I now know is an anxiety attack. With no I couldn't think of a reason why. My wife asked me, what do you think caused it? I don't remember at the time.
And can you describe what that felt like?
Sure. I thought I was having a heart attack. My heart started racing, my heart was pounding, my pulse was racing. I started to sweat. I started to feel tingling in my fingers. My father had died at 52 of a heart attack. Seemed like a pretty logical thing. Right?
Yeah.
And so, I think you asked me, what did I do? So, this is where the story takes a little turn, because I am very lucky to have a benefit that most of you don't. And that is, I'm married to a fantastic mental health physician with over 30 years of experience treating anxiety disorders, depression, ADHD, and a number of other things. I have my own personal psychiatrist, exactly, to put it that way. So I called her, and I said, I think I'm having a heart attack. She said, well, tell me the symptoms. And I started to talk about it. And so she started to talk to me, asked me to do some breathing exercises, asked me a few other things, and said, I'm not there with you, but I don't think that's what it is. I think it's an anxiety attack. And I was able to calm down enough that I was able to leave work and drive myself home.
Yeah. And then what did you do? Did you go to see a doctor? I mean, besides talking
Except
to
for what
your
I
wife?
live with, you mean?
Except for the wife.
Yeah, it's not good to practice on your family. Here's what I thought of at the time. That was a time where I said, I have to do something about this.
Yeah.
I've been ignoring it for literally 30 years. I have to do something about it. My wife has a real knack for sort of seeing trends in her medical practice. And she had seen this tsunami of anxiety that we see today coming 20 years ago. And how she saw that was her practice was overwhelmed with people, and she could no longer see people. She had to close her practice to new patients. And this is not uncommon with most psychiatrists these days. And she felt very bad about that because these people needed her help. And she thought that the only way to deal with it was to move upstream into prevention. Like, there will never be enough psychiatrists, psychologists, social workers, registered psychotherapists to treat the amount of people with anxiety, depression, other, attention and emotion regulation disorders. So she herself went to Boston and trained with John Kabat-Zinn, who introduced mindfulness to the Western world 40 years ago, and started to practice it herself and bring it into her medical practice, and saw tremendous benefits for herself personally and also for the patients that practice it in their families. So she had told me about this, and I went, yeah, come on. Like, I'm a business person. Like, what am I going to do, shave my head and wear purple robes and chant? Because that's what I thought it meant. And so I said, no, find me a psychiatrist, and I'm ready to do some therapy for it. So again, I was lucky, because most people trying to get a psychiatrist, they'll wait months, if not years. It's really an unfortunate situation. There's a huge shortage. But I was able to, through my wife, to get to somebody. And I went into therapy for over 3 years. I also, at some point, started taking medication. I took anxiolytics for a number of years. And it was helpful. Both the psychotherapy helped me and helped me deal with a lot of issues. And the medication helped me a lot. But at some point, I said to my wife, like, I don't want to take this medication the rest of my life if I don't have to. It had some side effects, even though it was helping, I just didn't want to. I wanted to try something different. And so I said to her, tell me more about this mindfulness thing, because now I'm ready to hear about it. Now before I rejected it. And that's kind of set me on a path that got me to where I am today.
So, okay. Tell me about, so you started in the mindfulness.
Yeah, I took what's called the Foundational Mindfulness-Based Stress Reduction course,
Yep.
MBSR, from a GP psychotherapist, physician here in Toronto. And it was, not to sound like an infomercial, it was transformative for me. It really was. Within 6 months, I had ended my psychotherapy with my psychiatrist and was off my medication.
Okay. Do you still experience anxiety?
Only every day of my life.
Okay.
But there's a huge difference now.
Okay.
It doesn't jerk me around. It doesn't rule me. It doesn't, it doesn't emotionally hijack me the way it did, 10 years ago or 20 years ago.
So you'd say you've learned how to manage it?
Yeah, I've learned how to live with it.
Yeah.
I mean, when I saw the title of this talk, like, for me personally, Conquering Anxiety gave me anxiety. Because what if I don't conquer it? Does that mean I failed?
Yeah.
And that made me more anxious. There's a great saying that my wife told me, which is, people who suffer from anxiety are anxious about being anxious. And people who suffer from depression are depressed about being depressed. And so sometimes I get anxious about being anxious.
I want to ask you another question. You're talking tonight about anxiety. Did you always talk about it? Was it something you hid?
No, I didn't talk about it. Certainly not to my business colleagues. Not in the 80s or the 90s, way before Bell Let's Talk or Michael Landsberg and Sick Knock Week or any of those initiatives like this to reduce the stigma of mental health. No, we didn't talk about it because people looked at you funny. You were worried about what your boss and colleagues might say or might think of you.
Why are you talking about it now?
Because you asked me to.
But, yeah, for sure.
Well,
Yeah.
because like I said at the beginning, I really believe in what you're doing here at Holy Blossom and what Sklar Wilton's doing in the business world. We have to shine a light on mental illness because it affects so many people, and the numbers are just increasing. And if I can help one person today just by me talking about it and my experience, because this is just my experience, it may not be yours, and if I can do something to honor my friend Luke's memory, then, that's why I'm here.
Thank you. I think that's your story, unless you have more to add.
Only that what really got me along the path to where I am today was understanding some of the neuroscience behind anxiety and depression. So one of the things that I said to my wife at some point was, look, you're a doctor. Show me the proof that it works. Show me the evidence. Show me this is evidence-based. And so she started to feed me articles and books on neuroscience of the brain, and while I'm not a physician, I consider myself a doctor by marriage. I was reading this work as particularly foundational work by a couple of people, Dr. Dan Siegel, psychiatrist out of Harvard, wonderful man who I've gotten to meet and know over the last couple of years, and in particular a guy named Rick Hansen, not the wheelchair athlete, a neuropsychologist out of California, who I've also had the fortune to get to know, mostly through my wife in conferences. And their work was foundational to teach me that, first of all, what I had, that voice in my head constantly nattering at me, telling me things, you're not good enough, you're not smart enough, boy, are you stupid. Everybody has that voice. And it's constantly nattering away. And I started to understand some of the science of the negativity bias of the brain and other things. And those things allowed me to say to myself, you know what? It's not only you, and there are ways that you can deal with it. You'll never get rid of it, but the ways you can deal with it. And if you ask people, my wife always says, if you want to find out how somebody is, don't ask them, ask their partner or ask their kids, because they'll never give you a straight answer. They'll say, fine. If you ask somebody how I am, I'm fine. But I see two of my kids somewhere in the audience there, two of my four sons, and if you ask them, and if you ask my wife, who could be here tonight, they would tell you I'm a different person. Is that right, sons? Thumbs up from Adam.
Maybe we should hear from them. Thank you. So, on behalf of the Luke Sklar Mental Health Initiative, I want to thank you for sharing your story with us. As you know, we're working really hard on stigma busting. We think it's really important, and this helps a lot. So just to the audience, if anyone has any questions for Hirsch, he will be around at the reception following tonight's speeches, whatever, following the end of this evening, and you can find him there. Thank you.
Thank you, Lise.
Okay.
Thank you.
So I'm going to ask Doreen Saskin to come up, and she will introduce Dr. Antony. Thank you. And I will get down without tripping, hopefully. Here, Doreen. Oh, you don't have that one. Okay.
Hello? Oh yeah, this works. Good evening, everyone. I'd like to extend a warm welcome to Dr. Martin Antony, a world-renowned, well-reputed, and often quoted psychologist and expert on anxiety. I was fortunate to attend a professional training workshop on anxiety given by Dr. Antony over 10 years ago. Given that I am a gifted worrier, I have followed his research and read and reread many of his excellent books. My personal favorite is called When Perfect Isn't Good Enough. He has authored 32 books so far, numerous excellent evidence-based self-help manuals, and many research texts and articles. Martin Antony is professor and graduate program director in the Department of Psychology at Ryerson University. He also holds faculty appointments at the University of Toronto and McMaster University. Dr. Antony has received numerous career awards and held millions of dollars in research funding. He spends his time training and supervising students and professionals in psychology and psychiatry. He has given more than 450 workshops and presentations across 4 continents and is very frequently quoted in the international media. We are very lucky to have Dr. Martin Antony here at Holy Blossom tonight to share his expertise in conquering anxiety. Please welcome Dr. Martin Antony.
Hey, thank you very much for that generous introduction, and it's a great honor and pleasure to be here tonight. So thank you for inviting me here. In case anybody is, I'm not sure if it was announced or not, but Caversham Booksellers is selling books outside. You may have also gotten a list of recommended readings. So I've got a sort of front and back list of recommended readings on anxiety and related problems that I prepared for tonight. I know Caversham has some of those available. I know they have all of them available in their store. So if they don't have something you're looking for tonight, you can find it there. And I'm happy to recommend readings afterwards if people are looking for books on specific topics. This is an outline of what I plan to talk about today. So I'm going to begin with just some definitions of terms like anxiety and worry and fear and panic, words that we think we know the meaning of, but psychologists and psychiatrists use those words in maybe different ways than we may generally use those words. I'll also talk just a little bit about the nature of anxiety and fear, so we have a sort of a common understanding of what we're talking about tonight. And we'll talk about strategies for managing anxiety and fear. Often when I'm doing trainings on this topic, we can easily go 2 days or 5 days or even longer. I spent 5 years training and how to treat these problems. So in the 45 or so minutes that I have, I'm not going to be able to go through every strategy that you can use for anxiety or to go through them in any kind of depth. But again, the recommended readings that I've recommended go into those in more detail. But I will talk a little bit about a couple of groups of strategies that have been studied the most for dealing with anxiety. And those will be strategies for changing anxiety-related thoughts. And second, strategies involving confronting feared situations, exposure-based strategies. I'll also talk, if we have time, a little bit about strategies for realistic anxiety. So a lot of the work that we do is focused on helping people whose anxiety and fear are out of proportion to the actual danger in the situation. But a lot of us are also dealing with anxiety that's not out of proportion to the situation. So you may be dealing with serious health problem in yourself or in your family members and may be anxious about that and wondering what you can do to help with that. And I'll talk a little bit on ways that you can get help in Toronto as well. So to start with some definitions, I just want to talk briefly about anxiety, fear, panic, and worry. And this is a definition of anxiety. And these definitions, they come from the Diagnostic and Statistical Manual of Mental Disorders, the DSM, which is the official book by the American Psychiatric Association that defines the different criteria for diagnosing different kinds of anxiety problems. This is the definition of anxiety. So it's apprehensive anticipation of future danger or misfortune accompanied by feelings of worry, distress, and physical symptoms of tension. The focus of the anticipated danger may be internal or external. So just to put these in different words, anxiety is really about future-oriented angst. It's the emotion that you feel when there's something coming up in the future that's making you anxious. Again, it can be internal. You may be worrying maybe about some symptoms that you're having, and maybe they're going to cause some serious problem down the road, or it can be an external focus. You may be anxious about a presentation that you have to give or an exam that you've got coming up or something like that. The key here is that it's future-oriented angst. Anxiety looks like this. So when we're anxious about something, we're worrying about it. So you can see this child here is sort of thinking about this thing that's coming up in the future. Fear is not the same thing as anxiety. A lot of us use those words interchangeably, but they're two different things. Fear is more of an emotional response to some imminent threat or danger. So we often describe fear as a fight or flight response. So when you're experiencing fear, there's a strong desire to get out of the situation. So this is not fear here. This is, again, anxiety. This is future-oriented angst. With fear, there's some sort of, again, perceived immediate threat. This is what fear looks like. So when we're afraid of something, we feel like something horrible is about to happen. You're about to get into a car accident. There's a bear chasing you. There's somebody breaking into your house. You feel like something is terrible is about to happen. Clinically, another term that we use to describe fear is panic attack. So the experience of a panic attack is essentially just a rush of fear, intense fear or discomfort that peaks within minutes. This is actually an old definition. I need to update this slide. It used to be required that it peaked within 10 minutes. Now they just say within minutes. And normally panic attacks peak within seconds. You can imagine if a bear was chasing you, you wouldn't want it to take 10 minutes to get scared. You'd want to have that response immediately so that you can get out of the situation as quickly as possible. And that's typically what happens with panic attacks. We also need to see at least 4 of these 13 symptoms. And you can see most of these are physical symptoms, things like sweating and shaking and racing heart and dizziness and breathlessness. But some of these are more psychological symptoms. So a fear of losing control, a fear of going crazy, or a fear of dying. It feels like something horrible is about to happen. You might feel like you're going to throw up or have diarrhea in public or faint or something like that. So that's the definition of panic attacks. Most of the time, panic attacks are triggered by something. So if you're terrified of public speaking, you might have a panic attack while giving a presentation. If you're terrified of snakes, you might have a panic attack when you see a snake. But panic attacks can also happen out of the blue. We heard a description of that earlier this evening, where you may just be sitting at home watching TV, feeling okay, and all of a sudden you start to feel dizzy and breathless, and it feels like you're maybe having a heart attack or you're about to die or faint or something like that, without any obvious trigger or cause. We call those unexpected panic attacks. This is a definition of worry. Worry is something that we see associated with anxiety, and I would consider this, think about this as the cognitive component of anxiety. In other words, the thoughts that go along with anxiety. So the definition here is that it's unpleasant or uncomfortable thoughts that can't be consciously controlled by trying to turn your attention to other subjects. Again, so when you've got a big exam coming up, you've got a big presentation, you've got a big meeting with your boss or a job interview, or you're getting married, you may be worrying about that, sort of having negative thoughts related to that. So those are some definitions. Moving on to just some basic ways of thinking about anxiety and fear. One thing that's very important to remember is that anxiety and fear are normal. We all experience anxiety and fear from time to time. In fact, if you didn't experience anxiety and fear, you'd probably end up getting yourself into trouble. If you didn't experience any anxiety at all, you'd probably say things that might put off other people or lead people to judge you negatively or things like that. So you want to experience some anxiety in situations to protect you in those situations. Which brings me to the second point, that anxiety and fear have a purpose. They're basically designed to protect us from possible danger. So when people experience fear, for example, their hearts race, they breathe more heavily, and those symptoms are designed to get more oxygen to the big muscles so you can escape from a situation quickly if you need to. The problem in anxiety disorders or problems with anxiety is that these symptoms occur even when people are not in the face of danger. We talk about anxiety and fear as having three components. And thinking about anxiety in terms of these three components can help to make it seem a little bit less scary and a little bit less dangerous and less overwhelming. So the first component is the physical component. The second component is the cognitive component, and the third component is the behavioral component. So it's essentially what you feel when you're experiencing anxiety and fear, what you're thinking when you're experiencing anxiety and fear, and what you're doing when you're experiencing anxiety and fear. So the physical component is all of those physical sensations that people experience when they're anxious or they're having a panic attack. So I mentioned some of these earlier, increased heart rate, breathlessness, dizziness, shaking, sweating, feeling unreal or detached, which you may not think about as an anxiety symptom, but it's actually a very common symptom that people experience during fear and anxiety. Blurred vision, sometimes things may seem like they don't quite look right. Blushing, people may, if they're anxious in a social situation, may get flushed. Numbness and tingling sensations. The cognitive component, again, this is a couple of different things. So part of the cognitive component are the thoughts, the beliefs, the predictions that people are making that contribute to their anxiety. So from a cognitive perspective, we don't react to situations in our life. What we react to is our interpretation of those situations. If you're predicting that being on an airplane is perfectly safe, you're not going to be anxious on the airplane. On the other hand, if you're predicting that the airplane is dangerous, that you're going to crash, for example, you may very well feel frightened or anxious on that airplane. So it's the predictions that we make, the thoughts, the beliefs that determine what emotion we experience in a given situation. We'll come back to that in a bit. Misinformation can contribute to anxiety as well. So if people misunderstand the meaning of certain kinds of symptoms, for example, that might lead them to feel more anxious in a situation. If people believe that they can get sick from touching certain things, they may develop fear of getting into contact with those things. So misinformation, beliefs, that's one piece of this. Another piece of this that's very important to think about, though, is the biases that we have in attention and memory. So we all tend to pay more attention to information that's consistent with our beliefs and we tend to ignore information that's inconsistent with our beliefs. And it's not hard to see that. If you just think about people's political views, for example. For many of us, when if we're watching somebody on television who shares our political views, we will likely agree with them and think, yes, that's important information that they're talking about. On the other hand, if somebody says something that we don't agree with, we'll often discount that or ignore that information. So what does that have to do with anxiety? Well, people who are anxious are much more likely to pay attention to information that's consistent with their anxiety-related beliefs. So somebody who's afraid of spiders is potentially going to scan the room looking for spiders. Anybody here know somebody who's afraid of spiders? Yes? Who's the first person in the room to find a spider if there is one? It's the person who's afraid of spiders, typically, who will find that spider first. We did some research years ago on panic disorder. So panic disorder is a problem where people have panic attacks out of the blue, and they're afraid of those attacks. So the attacks feel dangerous to them. And what we found in our research is that people who have these unexpected panic attacks are also scanning their bodies, looking for those sensations. We found that they're more accurate at counting their heartbeats, for example, compared to people who don't have panic disorder. So if you're looking for these physical sensations, you're going to find them. If you're looking for spiders, you're more likely to find them. People who are afraid of flying will pay attention to every plane that crashes, and they probably don't pay a lot of attention to the 10 million flights that take off and land safely for everyone that crashes. This next little video is sort of an illustration of this. It's basically an illustration of how if you're looking for something, you'll find it, and if you're not looking for something, you'll miss it.
This is an awareness test. How many passes does the team in white make?
Go!
The answer is 13. But did you see the moonwalking bear?
Okay, so how many of you have seen this before? There's a related one that uses a gorilla instead of a bear. Okay, so a small number of you have. For the rest of you, how many of you noticed the moonwalking bear the first time they showed it? One? Okay, so one. So not very many of you. And that's despite the fact that before I showed you the video, I said this is a demonstration of how if you're looking for something, you'll find it. And if you're not looking for it, you'll miss it. And you still missed it. That's how powerful this tendency is to only pay attention to what you're looking for. And again, if you're only paying attention, if I'm afraid of public speaking and I'm only looking at the people who look bored, for example, or look angry in the audience, that's going to reinforce my fear. And we have lots of studies showing that that's exactly what people do when they're afraid of public speaking. They notice the people who don't look like they're having a good time, and they ignore the people who look like they're enjoying the talk. So we all tend to do this. We tend to pay attention to our beliefs, information that confirms our beliefs. But if your beliefs are supporting these feelings of anxiety and fear, then that's going to help to keep your anxiety and fear alive. The third component I want to mention is the behavioral component. So we've talked about the physical component, the cognitive component, and the third component is the behavioral component. And these are the things that you do. With emotions don't just make us feel, they also make us act. And in the case of anxiety, there's a strong desire typically to do things to get rid of the anxiety. So if you think about anxiety, again, which is this future-oriented angst, what do we do when we're anxious? So if you're anxious about an exam, for example, that anxiety is actually there for a reason. It's there to motivate you to do something. And we tend to do things that will make us less anxious. So you may study, for example. If you study hard for your exam, you're going to be less anxious when you go into the exam. But you may also do the opposite. So I know when I was a graduate student, the time of year that my apartment was the cleanest was during exam time. That was the only time that I seemed to have the time to pull out the fridge and clean behind the fridge and clean my blinds, things that people generally don't do, because I wanted to do anything I could to not be anxious, and focusing on the exam would make me anxious. So those are examples of things that people do to manage their anxiety. With fear, what do you do when you're afraid? Again, if you're having a panic attack in a situation, maybe giving a presentation, what you might want to do is to leave that situation as quickly as you can. Or you might sit down, or again, do something to get rid of these horrible feelings. So the behavioral component involves avoiding feared objects, avoiding feared situations, avoiding feared sensations. So for example, if I was afraid of that racing heart feeling, I might avoid exercise, for example. I might avoid caffeine. I might avoid sexual activity. People also avoid feared mental experiences. I might avoid certain thoughts that make me anxious. We see that a lot in post-traumatic stress, where people try to avoid thinking about the memory of a trauma they've experienced. We might see that in obsessive-compulsive disorder, where people get intrusive thoughts maybe about harming a loved one. They might try to do everything they can not to think that thought. I'd like to try a quick experiment with you now. This is a little thought suppression experiment. What I'd like you to do is take about 15 seconds, I will time you, and not think about a pink elephant. Okay, so you can think about whatever you want, but just not a pink elephant. So you can start now. Okay, that's about 15 seconds. How many of you were successful at not thinking about a pink elephant? Okay, that's actually pretty good. So not very many of you, about 15 of you or something, but that's higher than I often see in audiences. So what we've learned is a couple of things. We've learned that it's actually hard to not think about something. So for many of you, that image was popping into your head. The other thing we know, though, from lots of research is that when people actively try to suppress an unwanted thought, two things happen. One is the thought becomes more distressing. So the more you try to not think about an unwanted thought, the more upsetting that thought becomes. The second thing is that some studies anyway show that the thought becomes more frequent. So there's a rebound period. So after the suppression period, people actually think the thought more than they would have if they had never tried to suppress it. So thought suppression doesn't work. Again, people do that when they're anxious. They try to not have the thoughts, memories, urges that pop into their head. But it doesn't work. If anything, it makes it worse. It may work temporarily, but it's not a great long-term strategy for managing anxiety. People also use what we call safety behaviors. They find subtle ways of avoiding situations. So for example, I might, during a presentation, I might sit down instead of standing. I might carry my medication with me everywhere I go. I might wear a turtleneck to hide blushing if I'm worried about blushing in front of others. So those are safety behaviors. So I would think of these, again, as subtle ways of avoiding. And avoidance, the reason we avoid to get rid of our anxiety and fear is because it works. But it's not a great long-term strategy for dealing with anxiety and fear. It works in the short term. When you leave the situation, you feel better. But you never really get to learn that the situation is safe. So in the long term, avoidance is thought to maintain anxiety and fear. And another example of a subtle avoidance strategy is using alcohol, drugs, or certain medications to manage anxiety. Alcohol, for example, acts on a neurotransmitter called GABA, which is short for gamma-aminobutyric acid. It's the same neurotransmitter that anxiolytic medications like Valium and Ativan and Xanax act on. So it's not surprising that alcohol takes the edge off. We don't recommend it as a treatment, but a lot of people have figured out on their own that that's a way that they can manage their anxiety. Again, in the short term, that will reduce people's anxiety, but it's not necessarily a great long-term strategy for managing an anxiety problem. The other thing I want to mention is everybody uses these strategies. So it's not that these strategies in and of themselves are a problem. We all do little things to manage our negative emotions through the day. These behaviors are only a problem if they're interfering with your ability to get over an anxiety problem. So if your anxiety is at a level where it's interfering with your life, it's causing problems for you, in that case, these behaviors may be part of that problem. Otherwise, having a glass of wine at the end of the day to take the edge off or whatever, or to having a glass of wine with dinner, that's not a problem. On the other hand, if you're having several glasses of wine every time you go into a social situation and you're having panic attacks in that situation, you're avoiding those situations as much as possible, then that may be a problem. I just want to mention some specific types of problems with anxiety that we often talk about. So one we've mentioned already, panic disorder. This is a problem where people have these unexpected rushes of panic out of the blue. They're afraid of those symptoms, they're afraid of the attacks, and they tend to do things to prevent those attacks. They use safety behaviors, and they start to avoid situations where if they were to have an attack, they wouldn't be able to get help easily, or they wouldn't be able to escape easily. And we call that agoraphobia. So some of you may have heard that agoraphobia is a fear of open spaces, or you may have heard it's a fear of leaving the house. It may be those two things, but usually it isn't. Usually most people with agoraphobia can do those two things. Agoraphobia is really a fear of any situation, again, where if the person was to experience panic-like symptoms, they wouldn't be able to escape easily, or they wouldn't be able to get help. So it may be waiting in line, it might be driving, it might be flying, it might be a crowded room. People may have to sit near the exit so they can escape easily. All of those are potentially frightening situations for somebody with agoraphobia. A specific phobia is a fear of a specific object and situation. So fears of snakes, spiders, dogs, cats, heights, blood and needles. Specific fears of driving or flying can be specific phobias as well. Social anxiety disorder is a problem where people have extreme social anxiety to the point that it's interfering with their life. You may be terrified of public speaking, but if you don't have to do it, you don't have a problem. On the other hand, if you're a teacher or a politician and you can't get in front of a crowd, then you do have a problem. So for all of these things, for us to call it a disorder or a problem, it has to be interfering with the person's life in some way, or it has to bother them that they're having the difficulty. So social anxiety is a fear of social or performance situations, public speaking, meeting new people, being the center of attention, dating, those sorts of things. Obsessive-compulsive disorder is a problem where people have obsessions and compulsions. And those two words mean something very different in OCD than they mean in everyday life. In everyday life, we talk about an obsession as being anything that somebody thinks about too much. So we talk about people being obsessed with their ex-girlfriend, or obsessed with YouTube, or obsessed with Dancing with the Stars. None of those are obsessions in the OCD sense. Those are just things that people think about a lot. An obsession is an unwanted thought, image, or urge that an individual tries not to have. So again, it's an intrusive thought, image, or urge. So obsessions include things like thoughts about contamination, intrusive thoughts about harming a loved one, for example. Intrusive sexual thoughts, unwanted sexual thoughts, unwanted thoughts of a religious nature. So all of those can be obsessional thoughts. Compulsions are the things that people do to deal with their obsessional thoughts. So people engage in compulsions. I would think of these as like safety behaviors. People who are having obsessional thoughts about contamination might wash their hands as a way of managing that anxiety. People who are having obsessions about losing things may have to check over and over again to make sure that they haven't lost those things. So that's the compulsion. The compulsion is the thing that people do to reduce their anxiety, to protect themselves, to get rid of their obsession. Generalized anxiety disorder is a problem where people worry too much, and they worry about their health, and they worry about their children, and they worry about their work, and they worry about money, and they worry about the world. They worry about the same sorts of things that everybody worries about. In GAD, the worry has to be excessive or out of proportion to the actual risk or danger in the person's life. And it also has to be at a level, again, where it's interfering with people's lives. It's maybe affecting their sleep or their relationships, their concentration at work, and so on. PTSD, this is a problem that's frequently misunderstood. In PTSD, the person has to have experienced a trauma, but it has to be some sort of physical threat to themselves or to somebody else. So for example, seeing somebody get killed, discovering a loved one who's died from some sort of unnatural cause, being attacked, being raped, being assaulted. All of those are PTSD traumas, living through a serious accident or a fire. Other kinds of sort of stressful situations like finding out that your spouse is having an affair or something like that, that is not a trauma according to the PTSD definition. It's terrible. It might make you anxious, it might make you depressed, but we wouldn't call it PTSD. It has to be a physical threat. And we also need to see certain kinds of symptoms. And one kind of symptom that really distinguishes PTSD from other kinds of anxiety problems is what we call intrusion symptoms, where the person is re-experiencing that past trauma. They're having constant memories of that trauma that they can't get rid of, nightmares, flashbacks where it feels like it's happening again. And there are other features as well. So people with PTSD experience a lot of avoidance. They avoid situations that remind them of the trauma. They're also very vigilant for possible harm. They may be looking over their shoulder for possible danger when they're walking down the street. Illness anxiety disorder is a problem where people are convinced that they have some sort of physical illness, and they may go to doctors frequently. They may avoid doctors if they're afraid that going to the doctor will just confirm their worst belief. But it's very much a focus on developing some serious illness or thinking that you already have one. So I want to move into strategies for managing fear and anxiety. And this is just a quick overview of strategies. I'm not going to be talking about all of these today. Cognitive strategies, which I will speak about briefly. These involve changing the anxiety-related beliefs, assumptions, and predictions that help to maintain people's fear and anxiety. Exposure. So this involves confronting feared situations, sensations, and mental experiences. If people are afraid of their thoughts, we would encourage them to have those thoughts rather than try to suppress them. We heard earlier tonight about mindfulness-based treatment. So there's emerging evidence, and I would even say it's not even so emerging anymore. Over the last 20 years, there's been quite a bit of research supporting the use of mindfulness-based treatments for anxiety, for depression, for a wide range of problems. Relaxation-based strategies. So these involve tensing and relaxing different muscle groups. We call that progressive muscle relaxation. Slowing down your breathing, sometimes called that breathing retraining. These have been found to be useful for certain kinds of problems, stress management, generalized anxiety and worry, for example. They're not so much going to help you with a phobia or with OCD or something like that, but for general stress and anxiety, those can be useful. Sometimes we include skills training. So for some people with a lot of social anxiety, so anxiety around meeting people, they may also, just from avoiding that situation, be lacking certain kinds of skills, or their skills may be rusty. So things like making eye contact or knowing how to make small talk, those sorts of things. And so we may incorporate that into the treatment. Someone who's very afraid of public speaking may benefit from learning some skills for public speaking as well. So we may incorporate that into the treatment. Driving phobias are very common. Most people that I work with are actually very good drivers. In fact, I prefer sometimes to drive with people who are afraid of driving because they don't tailgate, they don't text while they're driving, they don't read their email or whatever, they don't eat while they're driving, they have both hands on the wheel, they don't cut people off, they just basically drive. So again, most people who are afraid of driving drive very well, but every so often I work with somebody who's afraid of driving who should be afraid of driving. So often these are people maybe who haven't driven, they got their license when they were 16 and 40 years later, one person I worked with, for example, got divorced in her 60s after not driving for 40 or 50 years or something. And she just wasn't very good at it, just from not practicing. So in her case, it was important to include driving lessons. So we may include skills training. Problem-solving training is another example of a skills training strategy that we may teach people. So especially for depression or general anxiety and worry, just teaching people to solve problems in a systematic, orderly way can be useful. Lifestyle approaches. Exercise is emerging as an effective treatment for anxiety, for depression as well. There's more research in depression. We know that in depression, for a lot of people, exercise is as effective as antidepressant medications. And in anxiety, again, I'd say there's emerging evidence supporting exercise as well. We know that learning to sleep better, learning strategies for sleep can improve people's depression and potentially anxiety as well. Eating healthy. So we encourage people not just to be focusing on the symptoms, but also trying to live a healthy lifestyle more broadly. And then lastly, medications. I won't be talking a lot about medications today, but there is evidence supporting the use of medications as well, either on their own or in combination with cognitive and behavioral treatments, which we'll be focusing on more today. On average, in anxiety, medications work about as well as cognitive behavioral treatments. For some people, they work better. For some people, psychological treatments work better. And for some people, the combination seems to work best. And sometimes it's hard to predict in advance who's going to benefit from what. But all three of those approaches, in anxiety anyway, are about equally effective. Okay, I'm going to talk in a little bit more detail about two types of strategies. So the first is cognitive strategies. And one of the things when we're working with people using cognitive strategies is we want people to understand the link between their thoughts and emotions. I mentioned earlier, we don't react to situations in our life. We react to our beliefs about those situations, our interpretations of those situations. So these are a couple of scenarios that I might share with somebody. So imagine it's 10 p.m. Two neighbors have both heard a loud bang outside their house. One neighbor feels angry, and the other neighbor feels scared. They both heard the exact same noise. So what could account for them feeling differently in the situation? You both have the exact same experience, and yet you're having very different emotional responses to that situation. And the answer is you're interpreting it differently. One person is thinking, oh no, there's this loud noise, my neighbor's just been shot, and they're feeling very anxious. The other person is thinking, oh, there goes my neighbor making a bunch of noise outside, I'm never going to get back to sleep, I've got a big day tomorrow, and they're just ruining my night and ruining my day tomorrow. Well, that's going to make you feel angry. So depending on how you interpret the situation, you'll have a different response. Two people arrive home to a bunch of flowers from their spouses with an attached note that says, I love you. One person immediately feels worried, and the other one immediately feels happy. What accounts for that difference? Well, again, it's what you're thinking. So if I come home and I see a bouquet of flowers there and I think to myself, oh, I've got this wonderful spouse, aren't I lucky? I'm going to feel happy. On the other hand, if I think, what did you do? What did you break? You never get me flowers. Why do I have flowers here? I'm going to feel worried potentially. So cognitive strategies are all about helping people to shift their thinking from an anxiety-provoking kind of way of thinking to a less anxiety-provoking way of thinking. It's not about positive thinking. So the goal isn't just to walk through life with sort of rose-colored glasses and think everything's okay. The goal instead is to be able to look at things in a balanced way, in a more realistic way, and a more flexible way, to be able to look at things from lots of different perspectives. These are some thoughts that we might see in anxiety. It's important that everybody likes me. If I make a mistake at work, I'll get fired. If my heart skips a beat, it means I'm having a heart attack. I can't cope with thinking about my past trauma. Other people are going to notice my mistakes. And what we do is we encourage people to ask questions to challenge these kinds of thoughts. So for example, the thought, it's important that everybody likes me. I'd encourage people to question that. Is it really important that everybody likes you? Are there exceptions? I might ask, can you think of somebody that where it's really important that they like you? Anybody think of somebody where it's really important they like you? You can just scream it out. Your boss, maybe, your spouse. Most of us would want our spouse to like us. But what about at the other extreme? Is it important that if you're returning an item to a store, is it important that cashier likes you? Is it important if you see a baby in a stroller on the sidewalk, does that baby need to like you? What if they gave you a dirty look or something? What would the consequences of that be? So we might encourage people to see this belief that feels like it's important that everybody likes them, to see it more on a continuum. I might ask the question, is it possible for everybody to like you? Can you think of anybody that everybody likes? Probably not. Most of us can't. Can you think of anybody that everybody dislikes? Even then, it's probably hard to think of anybody that everybody dislikes. You might have a coworker or a boss that you can't stand. But does everyone feel that way? Is that coworker married? Does that coworker have friends? If so, you might not understand how that's possible, but some other people may look at that differently. So one of the reasons why it's impossible to be liked by everybody is that we all like different things. We tend to like people who are similar to us, who share our values, for example. You've heard the expression opposites attract, and you've heard the expression birds of a feather flock together. The research supports more birds of a feather flock together. We tend to prefer people who share our political views, our religious beliefs, our attitudes about things. If you work in a particular, I was in Iceland actually a couple of years ago, and I was in a restaurant, and I saw somebody at the table next to me, and they had a Canada t-shirt on. And I went up and talked to them. It turned out that they were from Canada as well. And I was just, it was the most exciting thing in the world. I just thought they were great. If I met them here, I'd want nothing to do with them. It's because I had this thing in common with them there that I didn't have in common with other people that made them more attractive to me. So we might have this sort of discussion with people, helping people to recognize that, again, the very things that might make you likable to some people are going to make you less likable to others. So we try to pick apart of the thought a little bit, help people to look at the evidence, and to come to a more balanced, more flexible conclusion based on the evidence. In anxiety, we often talk about two kinds of thinking. The first is probability overestimations. And this is overestimating the chances of something bad happening. So people will think I'm an idiot if I give a presentation. I'll have a heart attack if my heart races. If I get close to that dog, the dog is going to bite me. The plane is going to crash. I'm going to get attacked if I walk through the park. And the way we deal with this is by looking at the evidence. If somebody's convinced that the elevator is going to get stuck, we might go down to a busy building and see what happens. We might, for 15 minutes, count how many people get on the elevator. I might ask the person first, how likely do you think the elevator is to get stuck? And the person might say, well, I'd guess 1%. 1 out of 100 elevator rides get stuck. So we just count people getting on the elevator. And we might count 50 people getting on in 15 minutes or something like that. That's 200 an hour. Well, that means it should get stuck every half hour. But it doesn't. We ask the security guard, how often does this elevator get stuck? And the guard might say, every 6 months. Well, that's not 1 out of 100. That's 1 out of several hundred thousand. So that would be an example how we might look at the evidence to challenge that kind of thought. Now, sometimes people will say, yeah, but I could be that 1 in 100,000, and I don't want to take that risk. Which brings me to the second kind of thinking, and this is catastrophic thinking. This is overestimating how bad something would be if it were to happen. So if I were to get stuck on an elevator, that would be a disaster, for example. If somebody didn't like me, that would be unmanageable. If I were to have a panic attack at a theater, that would be terrible. I couldn't cope with that. And here we encourage people to ask this question here. What is the worst thing that will happen? What if you do get stuck on an elevator? Anybody here know someone who's been stuck on an elevator? Yeah, are they still stuck? No? Anybody who gets stuck gets unstuck. So the worst thing that happens if you get stuck is you might be late, you might be uncomfortable, you might be frightened, but people don't suffocate. The elevator doesn't drop to the ground. A lot of the things that people predict will happen don't happen. So we encourage people to ask this question, what's the worst thing that can happen? So what if I do have a panic attack? What if somebody doesn't like me? Now, we don't use this kind of question. If somebody was afraid during a panic attack that they were having a heart attack, this is not the kind of questioning I would use. So I wouldn't say, well, so what if you have a heart attack? What's the big deal? There we would focus more on the likelihood that it's a heart attack. In a lot of cases, people with panic attacks overestimate the likelihood of that. But the other thing that a lot of us do with other sorts of situations is we overestimate the importance of the situation. If my presentation doesn't go perfect, then I won't be able to cope with that. If I'm late for my appointment, that will be a disaster. And those sorts of situations are often much more manageable than we feel like they're going to be beforehand. So these are some steps in examining the evidence. Identifying the anxiety-related thought. So during my presentation, people will see my blushing, they'll think I'm strange. Generating alternative thoughts. Maybe people won't notice my blushing. Maybe some people will notice my blushing, but most people won't. Maybe the people who do notice will think I'm unwell, or I'm feeling hot, or I'm feeling a bit nervous. And maybe people will think nothing of it. They'll just think, oh, he's blushing, and the thought may just stop there. The third step is looking at evidence supporting my anxiety-related belief. I think my blushing is really extreme. A few in high school, some people would tease me about my blushing. I tend to notice when other people blush. But we also would look at evidence for my alternative beliefs, the non-anxious beliefs. So I know lots of people who blush easily, and people don't seem to think they're strange. When I see other people blushing, I don't think they're strange. Often people don't seem to have noticed me, my blushing, even when I ask them if it's noticeable. And when people do notice my blushing, they don't treat me any differently, generally. And then step 5 is to choose a more realistic belief. Some people may notice my blushing, but it's unlikely that they'll think I'm strange. Okay. What we want people to do, again, is to encourage them to ask these sorts of questions. What facts, what data, what experiences support my beliefs, my predictions or interpretations? Are there little things that contradict my thoughts that I might be discounting? When I look back at this a week from now or a month from now or a year from now, will it still seem as important as it is now, for example? Sometimes we'll use a form like this. We call this a thought record. This particular thought record comes from one of my books called the Anti-Anxiety Workbook. And here you use this thought record to challenge the thinking. So for example, I may be very anxious because my wife is late home from work. So I would write down the time and day, the situation, and then what my thoughts are. Well, my thought is that she's gotten into some kind of car accident. Maybe she's dead in a ditch or something like that. My anxiety is high. It's maybe a 90 out of 100. And here I list some alternative thoughts. There's other reasons why my wife may be late from work. Maybe she's caught in traffic. Maybe she had a late meeting. Maybe she's running some errands, for example. But I might ask myself, well, wait a second, I've been phoning her on my cell phone every 5 minutes and she's not picking up. That surely means she's dead. But again, we can look at other reasons why people don't pick up their phone. Maybe she knows that it's her annoying husband calling her every 5 minutes and she just doesn't want to deal with that. Or she's, her phone is in her bag, or she's driving. She doesn't want to talk on the phone while she's driving, or she's in a meeting or something. The next column is we try to look at the evidence and try to come to some realistic conclusion. So for example, we've considered lots of other reasons why she may be late and why she's not picking up her phone. Which of those reasons are more likely? So if we think about death, for example, so my first thought was that she's dead. Death is common, it happens to everybody, but it only happens to everybody once. Those other things happen to everybody all the time. We all get stuck in traffic, we all have our phones die or the sound's turned off. Those are things that happen all the time. And that might sort of push me more towards some of those explanations rather than that something terrible has happened to her. And then my anxiety hopefully would be a little bit less. So instead of 90 out of 100, it might be down to 50 out of 100. One final strategy that I want to talk about in terms of cognitive strategies is behavioral experiments. And this involves basically going out and basically conducting a little experiment to test out whether your belief is true. So for example, we saw somebody who had a lot of fear of being the center of attention. And he was worried that if he was the center of attention, two things would happen. First of all, people would judge him negatively. And second, he wouldn't be able to cope with that. So we developed this practice with him where he went into a coffee shop like a Second Cup or a Starbucks or something, and he purposely drew attention to himself. So he basically said, excuse me, I have an announcement. And everybody turned and looked at him. And he said, I just got engaged this morning. That was his announcement. And he was prepared for people to kind of roll their eyes and maybe call out some negative comments to him, and he was prepared to not be able to cope with that. Instead, the opposite happened. People burst into applause. Now, I would have felt a little bit guilty because he didn't really get engaged that morning, so he was not being honest, but he was okay with that part. So that's an example of the behavioral experiment. If I'm nervous about losing my train of thought during a presentation, an experiment might be to purposely, what was I going to say? Purposely lose my train of thought and see what happens. If I'm convinced that touching things that I feel are contaminated is going to be dangerous, I might do an experiment where I try touching things. So we encourage people to try the things that make them anxious and see what happens. Which brings me to actually I just want to mention one other strategy that we use sometimes, or a little experiment, I guess, that I want to share with you to challenge this thought. So this thought is the thought that people will notice every little mistake I make and they'll think I'm incompetent. So this is something that a lot of us have this thought sometimes. So the thought that if I have a bad haircut, everybody's going to notice, or if I've gained a few pounds, everybody's going to notice, or if I'm a little bit late for work, everybody's going to be focused on that. This little demonstration, I guess, is a bit of an experiment to sort of challenge that thought.
The door study. This video shows a participant from a 1998 study by Daniel Simons and Daniel Levin. Watch what happens as the unsuspecting pedestrian provides directions. The young man on the left is one of the experimenters. he has approached the white-haired man and asked for directions. Watch closely as two people carrying a door pass between them, and the first experimenter is replaced by someone else. Like many of the people in this study, the pedestrian was entirely unaware that he was talking to a different person. Approximately 50% of the people approached in this study didn't notice when the person they were talking to was replaced by someone else.
So, the message there is that, what are the chances really that if you've gained a pound or you're having a bad hair day that people are going to notice? Even if you turned into somebody else, only half of people would notice that. So, I just realized I did not look at the time when I started. Does anybody know what time I started? Around 7:30? Okay. So I'm going to, there's a few other things that I want to cover before we do a bit of a Q&A. I want to talk briefly about exposure therapy. Exposure is one of the most powerful ways of overcoming fear. And you've all benefited from exposure at one time or another. If you think back about try to think of a situation that you used to be afraid of that you're not afraid of anymore. So for example, it may be your first day on the job, you may have been very nervous. Or the first time you went on a date with the person who's now your partner, you may have been very nervous. Maybe when you were a child, you were afraid of the dark, and you're not anymore. How did you overcome it? Well, chances are you just did the thing over and over again. You kept going on dates with the person who became your partner eventually, or you kept going to work even though you were anxious, and it got easier over time. And that's essentially what exposure therapy is about. So it involves exposure to situations that people are afraid of, objects that they're afraid of, thoughts that they may be afraid of. People are sometimes afraid of the thoughts that enter their head, symptoms that they're afraid of. Not all exposure is effective. If you were afraid of snakes and I picked up a snake and threw it at you, that kind of exposure wouldn't be helpful. It might even make your fear worse. For exposure to be helpful, these are some basic guidelines. When we're doing exposure therapy, we want to do it in a way that's predictable, so there are no surprises. The person knows what's going to happen and when it's going to happen. We want the individual to also be in control. We don't force people to do anything. It's up to the individual to decide when they're going to do and the exposure, what they're going to do in the exposure. There's advantages of going slowly as well as advantages of going quickly. So we usually encourage people to go as quickly as they're willing to, but they don't need to go quicker than that. The more quickly people go in terms of taking steps, the more quickly they'll get over their fear. On the other hand, they're going to experience more anxiety by taking bigger steps more quickly. So everybody has sort of a different balance with respect to what they're willing to do, and that's fine. There's evidence that longer exposures work better than shorter exposures. So you can see here, this is the first, there's 4 exposure practices here. You can see the fear starts off very high, and it kind of stays around the same level for about 20 minutes, and then it starts to come down. If this person left the situation after 10 minutes, what they would have learned is when I'm in the situation, I feel terrible, and when I leave, I feel better. On the other hand, by staying for the whole hour here, they learn that their fear comes down, and they can be in the situation and not be afraid, which can be a very powerful lesson for people. You can also see that the exposure practices build on one another, that they get, if you look at this last practice, here the anxiety just comes up to about a 30 out of 100, and it comes down to 0 very quickly. So by doing exposure over and over, the practices build on each other, but they only build on each other if they're close together. So if you're afraid of public speaking and you had to give a lecture once a year or something, you'd never get over the fear. On the other hand, if you did it every day, like a teacher presenting in front of a class or something, you'd find within a week or 2 it would get much easier. So we want the practices to be close together. We want them to be prolonged. We want people to reduce the use of these subtle avoidance strategies, the safety behaviors that may be maintaining the problem. We also want people to not fight their fear. We talked about mindfulness earlier. Taking a mindful stance toward the fear, accepting it, letting it happen, rather than trying to make it go away. It's sort of like lying in bed at night trying to fall asleep. You can spend all night saying to yourself, I have to fall asleep, I have to fall asleep. Sometimes it's not until we stop trying to fall asleep that you actually do doze off quickly. I just want to talk about one other thing, and then we'll take some questions. So if you're interested in getting help for anxiety, or someone you care about is interested in getting help for anxiety, there are a number of different options. So there are self-help books out there that describe these treatments in some detail, and those recommended readings have that list on them. There are now online self-help treatments as well. Mindbeacon.com is a place where you can access online treatments. This is another example here, a digital app that's available through anxietycanada.com called MindShift. You don't need to remember that whole website. If you just go to if you just Google MindShift, actually, it'll come right up. Or if you go to anxietycanada.com, you'll find that. And then lastly, my website, which is martinantony.com, has a bunch of recommended referrals. It's mostly psychologists, but not all. And it's a mix of OHIP covered and private options. So note that Antony has no H. If you're looking for me, the website looks like this. And if you click down here on anxiety referrals, a whole bunch will come up. And a lot of these are people who I've worked with over the years, or I've trained, or I know something about their work. The default is Toronto, but if you live outside of the city, there are other options here as well. So Barrie is on there, and Oshawa, and I think, Markham is on here. So there are a number of sort of other GTA places on here. If you can click on those will come up as well. So I'm going to stop there. I want to thank you all for coming, and we have an opportunity to deal with questions. Thank you.
Hi, my name is Julie Solomon, and I'm on the board of directors at Holy Blossom Temple. I'd like to thank Dr. Antony for helping to decode the mystery of anxiety, which many of us suffer from on a daily basis. You've given us words and meaning and educated us in the nature of this disorder. Reaching out to family, friends, or professionals validates one's feelings and symptoms and may help one feel that they're not alone. Therefore, at this time, I'd like to ask some questions that I really appreciate that you have written for us. I hope I can provide you with a cross-section of various concerns that are written down here. So my first question is, for parents of children who experience anxiety, what are some skills or techniques that we can use to help our children? Is it something that we can do or we are causing, or is it strictly something that we should be teaching or the child themselves should be facing and treating? Yeah. So, the first thing I'll mention is that the children are a lot more anxious than they used to be. And there's data supporting that kids are more anxious than they were 20 years ago, for example. And I think there's a few things contributing to that. One thing is just this 24-hour access to news. So when many of us were younger, the news was on at 6 o'clock or something like that, and maybe again at 11, but we were asleep by then. And we didn't really watch the news because we were off doing other things, and we just weren't exposed to it the way we are now. And now it's on all the time, and you can access it anywhere, and it's on the internet, and it's hard to kind of get away from that news, and that may contribute to a sense of unpredictability and lack of control, which can make people more anxious. So I think that's one factor. The other thing, though, is that children are a lot more protected than they were many years ago. So I know when I was probably about 10 years old, I took the Bathurst bus every day down to school at near Lawrence on my own, from like Bathurst and Finch or something. So I wasn't on my own, sorry, I was with my 4-year-old brother. I remember Monday or Saturday morning, and Sunday morning, whatever, my mother would just say, "It's go out and play. I'll see you at lunchtime."
those kinds of things don't happen anymore. Nowadays, kids are connected to intercoms from the time that they're born to make sure that they're breathing and all of that, and they're just a lot more protected. And we know that if people are not allowed to take risks, it's the same way. If you're not exposed to germs, you don't build up physical immunities. If you don't get to take risks and make mistakes and hurt yourself and all those things, you don't build up that kind of psychological resilience in the same way. So what we can do as parents, I think, one is learn to tolerate some of our own anxiety and let our kids take some risks, within reason. At least the same kinds of risks that our parents let us take, or some of those risks anyway. We can also try not to accommodate. Accommodating involves basically making it easier for people to avoid. So if you're with a child and you're walking down the street and you see a dog there, and your child's afraid of dogs, and you say, oh, there's a doggy over there, you're afraid of dogs, let's cross the road to the other side. Your child's going to be more comfortable and it's going to be relieved having done that, but it also sends a message that when you're afraid of something, you should avoid it, which is probably the opposite, that message that we want to send. So at the same time, we don't want to be punitive or force kids to do things. I mentioned earlier that exposure doesn't work when the person doesn't feel a sense of control in the situation. So if you're forcing a child to do something, that could have the opposite effect. So you really want the child to be on board, and there's lots of ways that you can do that. So you can, if you're having the child try things that are difficult, say you've got a child who's avoiding going to school, rather than just saying, that's it, you're not avoiding going to school anymore, tomorrow you're going to school for the day, see if you can break that down into small steps. So a step may be going to school with the parents, sitting outside the classroom for a short period, and then gradually increasing that period, gradually increasing the distance of the parent from the classroom, so making it manageable. And with children, we often use rewards as well. So for an adult, I can say, if you practice exposure in a couple of months, your fear of driving is going to be better. And an adult will say, well, that's great, a couple of months, that's nothing. You say that to a child, a couple of months is an eternity. So you often need to find ways to keep the child engaged on a daily basis in doing these things. Anyway, I'll stop there, but there's a great book called, there's lots of good books on child anxiety. I think I have them on the recommended readings. One of them is by Ron Rapay, who's based in Australia, called Helping Your Anxious Child. I'll try to make my other answers briefer, sorry.
Okay, no worries, thank you. Okay, this is interesting, probably very relevant. If we are using coping strategies for our anxiety and they're working, and it's helping us to manage our anxiety, should we stop then using it?
Absolutely not. If it's working, then keep using those strategies. So I would, we all use emotion regulation strategies. So for example, you may look out your window and you see that your difficult neighbor is out there and you don't want to deal with that neighbor. So you just say to yourself, I'm going to wait till my neighbor's gone so that I don't have to deal with that neighbor. That's an avoidance strategy. But that's fine. If it's not, we all use basically we spend all of our lives trying to minimize negative emotions. So even deciding to come here, you might be thinking, am I going to like this thing tonight? And you might have the thought when you're choosing a seat, you're picking a seat that you're going to be happiest in. So we all make these decisions to minimize negative emotions and maximize positive emotions. If that's working for you, then that's great. The problem is sometimes the strategies we use in the long term start to contribute to the problem. So the solution becomes the problem. So, most of us get shy from time to time, and we may avoid social situations a little bit. If you're avoiding those situations to the point where you can't develop relationships and you can't interview for jobs, in those cases it may be important to let go of some of those coping strategies that are helping you in the moment but preventing you from getting over the problem in the long term. Yeah.
Okay, this is, I think a few people have expressed this concern. How do you know when your anxiety symptoms are impairing? I guess there's a continuum or a spectrum of issues.
Yeah.
And how do you know at what point they are rational or irrational? And when should you seek help? Some people just sort of just live with it, right? So.
Yeah, so it's, I guess in a way it's a little bit like back pain or something, some other kind of chronic problem. So there's no official cutoff. So, it's very clear in the extremes. So if you have like no anxiety, that's very clear that you probably don't need to get help. And if your anxiety is destroying your life and you can't leave your house or you can't drive or get places and you can't have relationships, then it's very clear that help may be useful, potentially. So the things that we look at would be the severity, and the other thing we look at is the chronicity. So a lot of us have periods where we have really extreme anxiety, but it may be a bad day that you're having or a bad week, or maybe it's related to some stress that you're having. You've got your wedding is coming up, or there's some medical issue that you or someone close to you is dealing with, and when that subsides, your anxiety kind of comes down to a more manageable level. So those are the things I'd be looking at: severity and chronicity, and again, it's sort of a subjective kind of decision. So is this bothering me? Is this something I want to do something about? And second, is it interfering with my life? Is it affecting my work, my family life, my other aspects of my functioning?
Great, thank you. I think in terms of the time, we'll have to stop with the Q&A, but I'm sure Dr. Antony would be happy to answer some questions outside of the hall.
Absolutely, yeah.
I'd like to thank our speakers, for sure, Hirsch, Foreman, for your willingness to share your personal experiences with anxiety and your messages of hope for those who have or continue to struggle with this disorder. Dr. Antony, thank you for teaching us about anxiety and to help empower us with the knowledge and insight into the disorder. Thank you, Jill Whitkin, who chaired this event, as well as our Luke Sklar Mental Health Initiative Committee, Doreen Saskin, Cheryl Sylvester, Lee Sklar, Shelley Birnbaum, David Rosenberg, Julie Markle, Lindy Rivers, and Deanna Levy. Thank you, Rabbi Goodman, for highlighting the benefit of sharing our experiences and fears around mental illness. For some tonight, it might mean turning to the person next to you in this hall to find out that they are having the same problems that you are. The Luke Sklar Mental Health Initiative was launched last year by Jill Whitkin as a tribute to Luke, who suffered from mental illness. His willingness to share his struggles with friends and colleagues was his way of increasing awareness of mental illness. Our talk last year on depression fostered considerable interest in this initiative and led us to broaden our committee's scope to include an upcoming multimedia educational series with Rabbi Goodman, an upcoming speaker series on topics including addiction and perhaps dementia, and we're going to introduce a mental health first aid training program for staff and clergy. Dr. Antony and Hirsch Foreman's talks this evening. We're very thrilled that you are here to share your knowledge and your expertise. And we have, as a committee, made a generous donation in your honor to the Luke Sklar Mental Health Initiative Fund. Please join us. Thank you. Please join us for refreshments in the Schwartz-Reisman Atrium, where a selection of Dr. Antony's books from Caversham booksellers are available for purchase, and social workers from Jewish Family and Child will continue to be here to provide support and community mental health resources. We also have a list of very comprehensive resources on our website under our LSMHI. Thank you again for supporting our program and for coming out tonight.
Thank you.